So this INICET is a common entrance test, okay, which is used for you to enter highly reputed institutions in India, in our country. Like this is the common entrance examination you have to write to enter AIMS, JIPMA, PGI, NIMHANS, and so on, right? So a lot of times that question, where do you come from at certain places matter a lot, right? Yes. So that is what, where do you finish your PG is going to carry a high value for you later on wherever you're going to settle. Okay. Like when Pooja introduced me, she told I'm coming from Madurai Medical College and then I did my post-graduation from CMC Vellore. Yeah. So I felt very happy, right? Yeah. Yes. So we'll start with the revision. Yes. Yeah. So I have just 1.5 hours and I have to quickly rush through the important questions. Before that, just one word. Yeah. So anatomy, like any competitive exams you take, around 12 to 15 questions come from anatomy. If the question is going to be difficult and you don't know, okay. But if it's going to be easy and you don't know, then you can't forgive yourself, right? Anatomy is important and easy, and you can damn sure get all these 15 questions correct, right? And second thing, concept based. Whether the questions are direct or indirect or integrated. When you know the concept, yes, if I've understood it right, you'll get it right. And the third thing, previous year questions. I've been, as Raghu told, we have been doing this for past 3-4 years in the field, and we have seen that more than 50% of the questions, luckily, they get repeated. Okay, so you have to know the previous year questions thoroughly, and then the image-based questions, cadaveric images, okay, they are given. And why is it this INICET is a bit tough, right? Because of the standard question. Okay, so a lot of multiple options and controversy will come whether the option is C or D, and you can't do your inky pinky there. Okay, and you have some depth of the subject only, you can tick it right. Okay, yes. Now we'll start with the session. Yeah. Who's going to answer me now? So what is the bone that you see here? This is radius, this is ulna. What is the pointer mark pointing towards? That's the middle radio-ulnar joint. Yes. Yeah, so what type of joint is it? Yes, that's the fibrous joint, isn't it? You see, it's also, yeah, it's connecting the, yes, syndesmosis. It's connecting the middle part of the radius and ulna. So now you can get another question later on. There's a 3 joints between radius and ulna, right? Who's going to tell me what type of joint is superior and inferior radio-ulnar joint? Yes, the superior and inferior radio-ulnar joint. What type is it? Yes, you can get a question in the upcoming years on the current INICET also, right? Yeah. So remember, we'll just quickly rush through it. Yes, yes, Shivam, you're right. Okay, so pivot joint, remember, SIM. What is that? The superior, inferior, radio-ulnar joint. And what does the M stand for? The median atlantoaxial joint. Yeah, these are the 3 joints. Only 3 joints in the body are pivot. Superior, inferior radio-ulnar joint and median atlantoaxial joint. Do you know the median atlantoaxial joint has another name? Anyone wants to try? The median atlantoaxial joint between the first and the second cervical vertebra can rotate your head. And what is it called? It's called the joints of... No. Yes, Anjana, very good, right? Yes. Okay, what are the examples for hinge joint? Can you tell me? Hinge joint in the body? Yes, you have the elbow joint, the interphalangeal joint of the digits, the knee joint, modified hinge joint. These are the hinge joints, right? Very good. Yeah, yeah, Tanzim, the ankle also. Saddle joint. What about the saddle joint? Yes, the first carpo-metacarpal joint of the thumb. Yes. Any other saddle joint? Yes. In the lower limb, the calcaneocuboid joint, and one more. Who's going to tell me? Very good, Hannah. Very good. The one between the incus. There are 3 ossicles within the ear, right? Incus, malleus, and stapes. The one between the incus and malleus. That is also an example for saddle joint, right? Ball and socket, I'm sure all of you will tell me, right? Hip is ball and socket, shoulder is ball and socket. I need two more. Who's going to tell me? Two more examples for ball and socket joint. Yes? In the lower limb, between the talocalcaneonavicular joint. Yeah, the head of the, yes, yeah, talocalcaneonavicular joint. And one more, between incus and stapes. Right? Please remember that. Okay? You're not supposed to forget it. Condylite joint, wrist joint, and the knuckle. Yes, the knuckle joint. Yeah. The metacarpophalangeal joint are examples for condyloid. Also, the one between the atlas and occiput. Atlanto-occipital. Right? They are called the ellipsoidal joints. Plane joint. Yes, wherever the gliding movements are possible, between your carpal bones, between the tarsal bones, right? And once they have asked in the previous year, the joint between the rib and the vertebra. Yeah, what do you call it as? Costovertebral, or the between the transverse process, costo-transverse joint. These are example for, yes, costovertebral, costo-transverse joint are example for plain synovial. And one more in the upper limb. Yes, the acromioclavicular. Acromioclavicular joint is again an example for plain synovial joint, which have been asked. Okay. Yeah. Coming to the cartilaginous joint, you have the primary cartilaginous joint and secondary cartilaginous joint. What is the other name for primary cartilaginous joint? Synchondrosis. Secondary cartilaginous joint, symphysis, right? So synchondrosis, what is the example? Yeah, as you see here, yes, the joint between the diaphysis and the epiphysis, I have the growth plate and the first, okay, the first rib is fixed, the first chondrosternal joint. Yeah, the between the first rib and the sternum, that is example for primary cartilaginous. Secondary cartilaginous or symphysis, midline joints in the body, okay, manubriosternal, ziphisternal, pubic symphysis, and very important example, the joint between the vertebrae, the intervertebral joints. Okay, so this part, general anatomy, the joints topic has been asked repeatedly. So it should be at the tip of your fingers, right? And every time, every year, they ask one histology question. First MBBS, histology is difficult, right? How will you remember histology, like the normal histology for your after your final MBBS, right? So the few things are very important. INICET 2022, this was the image asked. Okay, I'll put another one here. So what is this? This is the image of thin skin. You get to see the hair follicle, right? This is the hair follicle. You know what they asked? To identify the merocrine glands. What do you mean by merocrine glands or eccrine glands? Which empty the secretion by exocytosis. Yes, sweat gland. So what is the sweat gland here? Yes, you want me to zoom the picture a bit? Yeah. So A that you see here is the sebaceous gland. Yes. And yeah, B that you see here, this is the sweat gland, right? So that was the one asked last 2022. And let's come to the next image. Yes. What is this epithelium that you see here? That's the respiratory epithelium. Can you make out the cilia here? A is the cilia, right? And what is B? You can see nice that mucus at the top of the cell. That's the goblet cell. Yes. What is C? The nucleus of the epithelial cell. And what is D? The basement membrane of the epithelium. You know what was D given as lamina propria, and they asked you to identify the incorrect one. Okay, so that's the respiratory epithelium. And the year before that, in INICET 2020, this was the image given. See, that's the same respiratory epithelium. And you know what was asked? The market appendage. What is this market appendage? It's the cilia. Yeah, that comes with repeated practice. Okay, Sneha? Yes, you get to see it again and again. While teaching, while in your routine classes, you'll be learning everything. But when you come for your PG entrance exam preparation, we concentrate only on the high yield topics. You get to see it again and again, right? So Celia was asked, and it was what were the options given is oviduct, vas deferens, ependyma, and one more. Yes, bronchi. Okay. So where does the marked appendage is not present? Okay, who's going to tell me that? Which is the area which is which of these following things doesn't have the cilia? Yes, ependymal cells. Where do you find the ependymal cells? Ependymal cells are seen in the lining of the ventricles of the brain, which are going to secrete CSF. They have cilia. Okay. Bronchi is part of the respiratory tract that will have the cilia. Oviduct is the fallopian tube that has a simple columnar epithelium with cilia. Then which one is the odd one out? Yes, vas deferens. The male reproductive tract, the vas deferens, epididymis, what are they provided with? They are provided with stereocilia. Yes, very good, Shivam, right? Okay. And like INICET 2020, they've asked this. Reticular fibers are not found in. Who's going to tell me? So what is the tissue given A, B, C, D? Yeah, you can make out all these are lymphoid tissue. Can you appreciate that? You can see the blue here. You can see the blue. All these blue dots are the nuclei, right? Yeah. So all these blue dots are the nuclei. All these four are lymphoid tissue. You know, in a lymphoid tissue, the reticular fibers, they form the stroma, right? But which one of these is not provided with reticular fibers? Even without the image, you can make it. You have to tell me the answer, right? So what is A? A, yes. Who's going to identify A for me? Can you identify what epithelium is this? That's the non-keratinized stratified squamous epithelium, right? Non-keratinized stratified squamous epithelium with the lymphoid tissue, you see, what are you going to take? It's the tonsil. Okay, you see lymphoid tissue and an epithelium, it is tonsil, right? What is B? See, you see lot of red, right? Lot of red and blue here. The lymphoid follicle, which has 80% red pulp and 20% white pulp. It's going to be spleen. Yes, spleen, Hannah, spleen. Okay, lot of red and little bit of blue. Yes, spleen, Hannah. Yeah, C. See, what is that you see here? An outer, it is all blue, but the outer blue is darker, inner part is pale. This is the medulla, this is cortex. And if you zoom out the medulla, you'll get to see a lot of pink structures. The Hassel's corpuscle. So what is this slide? Yeah, that is the Hassel's corpuscles are present in thymus. Yes, Anjana, very good, right? Yeah. What is D? This entire thing is going to be the cortex. This is the medullary sinus. You can see the lymphoid arrangement, right? In the cortex, this is your typical lymph node, right? Yeah, typical lymph node. Okay, so where is the reticular fibers not found? Reticular fibers are not found in thymus. Okay, yeah, thymus is provided with reticuloepithelial cells and not reticular fibers. Okay. And then this one, they keep asking this question again and again. I put a red color stamp. Every year, same topic will be kept in another format. Okay. Yeah, someone has to mute your okay, da. So this is like, I don't know whether the first MBBS would have done. Yes, Shivam. So what is pointed out here, you can see a nice big flask shaped cell. It's called the Purkinje cell. Okay. So this topic as such is very important. So this is cerebellum in the, and that you see here is the Purkinje cell, a magnified view. Okay, Tanzim. Yeah, still you can learn it. The more you get to hear it again and again, it's going to be there in your memory. This is a full view of the cerebellum. So you know the cerebellum has a outer gray matter and inner white matter. So this pink that you see here is the white matter. This entire thing is going to be the outer gray matter. The outer gray matter, you call it as the cerebellar cortex. They keep asking this question again and again in different form. So the outer cerebellar cortex has 3 layers. What are they? Outer molecular layer, and then middle Purkinje cell layer, and inner granule layer. Okay, so what are the cells present in the outer molecular layer? You get to see the stellate cell and basket cell, right? Middle Purkinje layer, Purkinje cells. And the granule layer has 2 cells. One is your granule cell and the other is the Golgi cells. Yeah, these 2. Now, I've mentioned you how many cells? Golgi, granule, stellate, basket, Purkinje. In the ungula, only one is going to be excitatory. Any idea what is it? Granule cells. Only granule cells are excitatory. All the others are inhibitory. So Purkinje cells are going to be inhibitory, right? And what are they going to inhibit? The deep cerebellar nuclei. Okay. And there are 4 nuclei, right? How do you remember? D, E, G, and F. Right? D, E, G, F. This one larger, you see it as a crumbled bag appearance. What is it called? Dentate nucleus. Right? This small one that you see here, yeah, that is the emboliform nucleus, right? And the third one, right, you see as a semicolon, what is that called? Globose nucleus. And the other one, closer to the midline, yes, that is called the fastigial nucleus. Okay. So our Purkinje cell that we saw, that a nice big flask-shaped cell in the middle layer, is inhibitory to all the cerebellar nuclei, right? Yeah. What are all these? First years will be able to answer better, I think. Yes, deep cerebellar nuclei, right? It's inhibitory to the deep cerebellar nuclei. Yes, guys, what is this? Cartilage. Very good, yes. So you're going to tell me what cartilage is it? Where do you find it? Yes. So here, this is the hyaline cartilage, this is elastic, and this is fibrocartilage. Yes? Yeah, hyaline cartilage and elastic cartilage, you can see the perichondrium, right? Yes? Fibrocartilage, no perichondrium, right? How to identify this? See here, in hyaline and elastic cartilage, you get to see isogenous cell nest, okay, where in fibrocartilage you get to see more of fibers, okay, lot of fibers. Here you see the cell nest, okay, that you can differentiate fibrocartilage. How to differentiate hyaline cartilage and elastic cartilage? Hyaline cartilage is going to have a basophilic matrix, okay, the matrix is going to be more of blue, right? And you won't see any fibers, no fibers in the matrix, okay, because it has the same refractive index as the matrix. So homogeneous basophilic matrix. Elastic cartilage, you get to see the fibers, the branching elastic fibers will be that. It is not basophilic. Now tell me, where are the areas you get to find the hyaline cartilage? Because they can ask you. Yes, hyaline cartilage you find in your, yes, trachea, the laryngeal cartilages. Yes, then growth plate, right? Growth plate, yes, articular cartilage, growth plate, yeah. Costal cartilage, the one which connects the rib to the sternum. What about elastic cartilage? The 3 E's, epiglottis, eustachian tube, and the pinna of the ear, the 3 E's, yes, yeah. And fibrocartilage, yes, the intervertebral disc, the labrum, glenoid labrum, acetabular labrum, yes, the menisci, medial meniscus, lateral meniscus, all that is made up of fibrocartilage. Fine? Okay. Yes. Now we saw about general anatomy, joints, histology. What slides did we see? We saw about cerebellum, cartilage, lymphoid tissue, and yeah, respiratory epithelium, right? Now upper limb, over the years, we have found that upper limb high yield topic was the nerve injuries. It's about median nerve, radial nerve, ulnar nerve, axillary nerve, musculocutaneous nerve, Erb's palsy, Klumpke's palsy. These are the things they ask repeatedly. Okay, so you should be in and out of these topics. Everything you should know. Yeah. So who's going to answer this? Yes. So what is the muscle mark? It is the hand, right? Intrinsic muscle of the hand. You see the thenar muscle here. You see the hypothenar muscle, and you see 4 worm-like muscle. 1, 2, 3, and 4. The one that is marked is the lumbrical. Which lumbrical? First or fourth? The first lumbrical, isn't it? Yes. What is its nerve supply? First lumbrical, first and second is going to be supplied by median nerve. Right? The median nerve also supplies your thenar muscles. What are the thenar muscles? Abductor pollicis brevis, flexor pollicis brevis, opponens pollicis. The third and fourth lumbrical is going to be innervated by ulnar nerve, isn't it? What are the other muscles supplied by ulnar nerve? Who's going to tell me? Yes, ulnar nerve in the hand. In the hand, it supplies. Can you identify what muscle is this? Yeah, so it supplies. The superficial branch will supply palmaris brevis. The deep branch will go to supply the hypothenar muscle. And then, yes, as we saw now, third and fourth lumbrical. What else? Yeah, palmar interossei, all the palmar interossei, all the dorsal interossei, and not to forget, yes, what is this muscle marked? It's going towards the thumb, right? See the direction of the fibers. Very good, Anjana. That's the adductor pollicis. Okay, so you should be aware of that. Yeah. So what is special about the middle finger? Who's going to tell me? That was asked once. Yes, you know the action of the palmar interossei is? What is the action? Pad, isn't it? Adduction, adduction. Okay. And the dorsal interossei, what is the action? Dab, isn't it? Abduction. Okay. So remember what is special about the middle finger. Middle finger adduct panna mudiyuma. Middle finger is already in the axial plane, right? You can't adduct it. So the middle finger, please remember. Yes, what will you remember? It has no palmar interossei. But you can move the middle finger, right, in either direction. Yes, right and left. So it will have 2 dorsal interossei. The second and the third. You can see it here, right? The second and the third will insert into the middle finger. Got it? Once they've asked that. Okay, now who's going to answer this? Starting less on therima. INICET, they ask controversial questions. Okay, sometimes you might be like close to the answer, but you're not very sure of it. Which of the following muscle is not used in overhead abduction at shoulder joint? This term, not, correct, incorrect, which is false, all the terms you have to pay a little more attention. Okay. So serratus anterior, will it cause overhead adduction? Of course. Trapezius, yes. Deltoid causes abduction up from 15 to 90 degree. Pectoralis major, it doesn't cause abduction at all. So there's no inky pinky work here. Which one would you like to choose? Yes, of course it is. Yes. Which option is better, C or D? We can click on which? D, right? Yes, so this is how we have to decide. Yeah, you can identify, right? So this is your trapezius. What is its nerve supply? Trapezius nerve supply another. Come on, guys. Trapezius nerve supply. Spinal accessory. Deltoid nerve supply. This is your deltoid nerve supply. Axillary nerve, right? And pectoralis major by the medial lateral pectoral nerves. Can you see the serratus anterior here? What is its nerve supply? The long thoracic nerve, right? So you should be able to identify in the image also, because you get a lot of image-based questions, cadaveric images also. The next question, recently, like in 2021, they've asked, the given deformity is due to which of the following nerve injury? Yes, what you see here is the little digit and the ring finger and the little finger is bent. You call it as a clawing, right? So that is due to involvement of the ulnar nerve, right? It's a very straightforward question. There's nothing to complicate at all. And again, 2022, they have asked this. The lower brachial injury leads to Klumpke's paralysis. The characteristic clinical finding is, please wait and see. Yes, Klumpke's is going to involve lower trunk, C8 and T1, isn't it? Yeah, it involves both median nerve and ulnar nerve. Policeman tip is seen in Erb's palsy, right? C5 and C6. Wrist drop is seen in radial nerve injury, right? And Horner syndrome is due to involvement of the sympathetic fibers, of course, seen in Klumpke's. Claw hand is seen in both medial and ulnar nerve injury. So the best option will be to take the claw hand, right? So quickly, can you tell me, they keep asking about ulnar nerve, right? So you should know better, little more about the ulnar nerve. What is A, B, C, and D? A is book test. What is the muscle tested? You're adducting the thumb to hold the book, right? The muscle tested is adductor pollicis. If the ulnar nerve is injured, you can't hold the book by adduction. You just flex your thumb. And what is that sign called? That sign where you flex the thumb to hold the book, that sign is called Frohman sign in ulnar nerve injury. What is B testing? B is called as card test, right? What is the muscle tested there? You hold the card by keeping your fingers closed, adduction, right? So the muscle tested here is, which is causing adduction of your digits? Palmar interossei. Very good, Dr. Jayant. Yes, Shivam. Yeah. Igawa test. See what is happening. You try to move the middle finger, try to abduct it, right? Either by moving left and right. So which muscle are you testing? Dorsal interossei. Okay. This D where you're not able to keep the little finger adducted, that is called as Wartenberg sign. Again, that's the adductor of the little finger. Okay. The little finger is not obeying. It's not coming close at all. Okay. This just quickly, can you tell me what alone? This is seen in median nerve injury, all these. Yeah. So what is the first diagram? First one called? Yes. Since I have very little time, I have to go a bit faster. Yeah. That's the hand of benediction. You're not able to flex the distal phalanx. Okay. Anything that involves the thumb, what is this finger? Index finger and the middle finger. Remember, it's the median nerve. Okay. And what is this called? Pointing index. Again, you're not able to flex the distal phalanx, FDP, flexor digitorum profundus. What is this test called? Pen test, right? Yeah, what is the muscle tested? Abductor pollicis brevis. Okay. This is ape thumb. What is the muscle paralyzed here? Opponent's pollicis. This is again clawing of the thumb, index and middle finger. So it will be due to paralysis of first and second lumbrical. And all of you know, I think all of you know about this OK sign. Yes. What nerve is injured here? Anterior interosseous nerve, a branch of median nerve. What are the muscles supplied by anterior interosseous nerve? Flexor pollicis longus, which is going to flex your thumb. Flexor digitorum profundus of the index finger. Okay, so when I do this, what will happen? Another is pronator quadratus. So if I'm able to make a perfect O, which means that I'm able to flex my thumb and my index, my anterior interosseous nerve is okay, right? But if my anterior interosseous nerve is paralyzed, I can't flex my middle finger or the thumb, and I get like this. Okay, so this is called as anterior interosseous nerve syndrome. Or what is the other name? Kevin, seen in Kevin-Nilo syndrome, right? Yes, what is this? What is the arrow pointing at? What is that? Identify the deformity. Come on. The patient's hand is dropping, right? This is the wrist drop. What is the nerve injured? Okay. So as I told you in your INICET exam, they give cadaveric images. And yeah, this image is, what is this showing? Cubital fossa image. They've asked more than twice. Okay. Yeah. cubital fossa image. So this is the medial epicondyle. You can see it's a bit more bulging, right? Medial epicondyle. So what are the structures in the cubital fossa from medial to lateral? Very good, Goba. Yes, you can see the median nerve here. This is the brachial artery. You can see the biceps tendon, and this is the radial nerve. Yes, yeah, very good. Most of you would have got. So usually what they do is they'll point out a particular structure and the sub questions will be based on it. Okay, so you should be able to know everything. Axillary nerve, again, it's going to wind around the surgical neck of humerus. It can be involved in the intramuscular injection if it's inadvertently inserted, right? If you give an injection in the wrong place into the deltoid, that can accidentally injure axillary nerve or the radial nerve. And what are the features of axillary nerve injury? Patient will not be able to abduct, right? He will not use that muscle at all. It goes for atrophy, and the rounded contour of the shoulder is lost. So the shoulder will appear more of a square instead of that round contour. And to remember, yes, they've asked this. It has one cutaneous branch. What is it? Upper lateral cutaneous nerve of arm. This is very important, the cutaneous component of axillary nerve. Yes, so in axillary nerve injury, the upper lateral part of the arm, there is no sensation, and this goes by the term regiment's badge of anesthesia. Okay, they've asked this over the previous year. Please remember. Yes, last but important, cutaneous innervation of hand. Yes, Anjana. So you know that I'm sure all of you will be knowing it, but this also they've asked repeatedly. So 1.5 on the palmar and on the dorsal aspect is by the ulnar nerve, right? The 3.5 that you see here, the lateral 3.5, and over the dorsum, over the distal phalanx and the middle phalanx is by the median nerve, right? Okay, and this part over the dorsum, this is by the radial nerve. Now, who's going to tell me carpal tunnel syndrome? Which area is pad? Carpal tunnel syndrome la handler sensation will be pad digit or over the dorsum, yeah, or palmar surface. Which part? This part, the skin over the thenar eminence. This part is pad because the palmar cutaneous branch of median nerve, it goes above the flexor retinaculum. Okay, the median nerve goes below the flexor retinaculum, but the palmar cutaneous branch, it escapes the carpal tunnel, and therefore this sensation over the thenar eminence is preserved in carpal tunnel syndrome. Please remember, guys, that's a point you should remember. Okay, with upper limb. So what did I tell you in upper limb? High yield topic is all about the nerves, the muscles, the test done. Okay, all that. Lower limb also yes, they keep asking this question in different image. Yeah, identify the nerve passing along the marked structure. So what is the bone marked here? The bone that is marked here is, yes, which one? Fibula, right? Fibula, yes. Which part of the fibula? The neck of the fibula. And what is the nerve that's going to wind around the neck of fibula? Yes, Annapurna? Yeah, common peroneal nerve, okay? Yes, the common peroneal nerve, it winds around the neck of the fibula. This common peroneal nerve is going to divide into superficial peroneal and deep peroneal nerve. So the deep peroneal nerve is going to supply the muscles in the anterior compartment of leg. What is the action of these muscles? Yes, what is the action of these muscles? Action of the muscles in the anterior compartment of leg is to, yeah, they're supposed to, yes, extend or dorsiflex. So injury to the common peroneal nerve, where the deep peroneal nerve is also injured, what can happen? The patient will not be able to dorsiflex and can present with foot drop. Okay, so that is the point you have to remember. Okay, this they keep asking again and again, guys. Okay, now this is another much more important question. Okay, patient with positive Trendelenburg sign, what is the action of muscle involved? Yes, so no, that's not the answer. What is Trendelenburg sign? So, this is the, this is right. And, sorry. This is your left leg. This is the right leg. When my left leg is off the ground, there's a tendency for the pelvis to sink on the left, right? But what is supporting it? Which muscle is supporting it from the opposite side? Yes, gluteus, medius, and minimus muscle of the opposite side is preventing the left pelvis from sinking. So if my left pelvis is going to sink when I lift my left leg, then which side muscle is paralyzed? Right gluteus medius and right minimus. And what is the nerve injured in that area? What is the nerve injured? The right superior gluteal nerve, right? The right superior gluteal nerve, it goes on to supply the medius and minimus. What is the nerve supplied to gluteus maximus? That is innervated by inferior gluteal nerve. Now coming to the action of these muscles, because that's what they have asked, right? Yes. So what is the action of gluteus maximus? Who's going to tell me? The very first action of gluteus maximus is extension of the thigh. And of course, that's the big lateral rotator of your thigh, of the hip joint. And the upper fibers of that muscle also cause abduction. Okay. What is the action of gluteus medius and minimus? Yes, they are, please make a note, it's asked repeatedly, medial rotators, medial or internal rotators and abduction. Who's going to tell me? What is the other muscle supplied by superior gluteal nerve along with gluteus medius and minimus? Yaru solla pora? Come on. Superior gluteal nerve supplies 3 muscles. Which one, Shivam? The tensor fascia lata. Right? Please remember that. Okay. So you know about Trendelenburg sign, you know about the muscle causing it, you know about the nerve supply, you know about its action. And you know what did they ask one time? Yes, they asked like this. They pointed out on the humerus bone and asked indirectly about Trendelenburg gait and muscles. Okay. Now who's going to tell me? What is the muscle inserting into A? This is your greater trochanter. This is the lesser trochanter. What is inserting into lesser trochanter? Iliopsoas. Am I right? Greater trochanter or anterior surface into A will receive the insertion of gluteus minimus. C is going to receive the insertion of gluteus maximus. What is D here? That's the gluteal tuberosity, which receives few fibers of, I'm sorry, this one here is gluteus medius. C. Gluteal tuberosity will receive the insertion of gluteus maximus. The topic as such is important, okay? The questions can be put in different ways. Okay, so this topic about Trendelenburg gait, the gluteal muscles, the nerve supply, and their attachments are very, very, very important. Okay, this was recently asked, right? Last year, yes. Which of the following market structure are affected in terrible triad of knee, which is also called the O'Donoghue triad, right? Enela, medial meniscus, tibial collateral ligament, and anterior cruciate ligament. Can you identify those here? So this is the, you can see the fibula here. So this is the medial condyle of tibia. This A is the tibial collateral ligament. Okay. B is the medial meniscus and C is the anterior cruciate ligament. So which is right? Okay. This was also asked last year. Ligament connecting medial cuneiform and second metatarsal bone. Do you have any idea about it? Because in first MBBS, we don't talk much about it. In ortho, you must have learned it. Yes. So what are these important ligaments that you're supposed to know in the foot? Yeah. What is spring ligament? I'm sure spring ligament you'll be knowing, right? So what are the bones you see here? This is calcaneum, talus, and this is your naviculum. So which aspect of the foot you're viewing now? From the medial aspect, right? And you can see a ligament bridging the calcaneum and the naviculum, which is called as the plantar calcaneo-navicular ligament, or the spring ligament. Okay, yeah. Then the other ligament on the medial aspect is your deltoid ligament, supporting the, yes, medial arch. What is this ligament connecting the medial cuneiform and the base of the second metatarsal? It's called the Lisfranc ligament. Okay, so this might be new to the others. Okay, Lisfranc ligament connects the medial cuneiform and the base of the second metatarsal. There was one more ligament, right? Chopart ligament. Yeah. What is this Chopart ligament? So it starts from, it's Y-shaped, okay? It starts from the calcaneum. It will send one slip to the cuboid and one slip to the naviculum. Yeah, this is called the calcaneo-cuboid navicular ligament. Bifurcate ligament, okay? It's called the bifurcate ligament, which connects the calcaneum with the cuboid on the lateral aspect and the naviculum on the medial aspect. Chopart ligament, right? We saw the cutaneous innervation of hand. Now we can see the cutaneous innervation of the dorsum of the foot, which is much more important. Who's going to tell me what is this green area? This is the area of the skin which is going to be innervated by saphenous nerve. Which structure does the saphenous nerve accompany over the ankle? Medial aspect of the ankle. Great saphenous vein. From where is the saphenous nerve going to come? From the femoral nerve, posterior division. Okay, you should know in and out of it, because one time they've asked, a procedure was done over the great saphenous vein and the structure accompanying it was injured. So where will be the loss of sensation over the foot? Okay, so this is a very important topic. And then coming to this yellow area, who's going to tell me? Very good, Dr. Jain. That's the deep peroneal nerve. Now the deep peroneal nerve, we saw it's going to supply the anterior compartment of the leg, and its lesion, like its injury can lead to foot drop, right? Foot drop. This blue area is the sural nerve, and the sural nerve is going to come from, it's a branch from the tibial nerve. And this most of the area over the dorsum of the foot is going to be innervated by, this was asked over the previous year. Yes, this is by the superficial peroneal nerve, okay, which is going to supply the everters of the foot, peroneus longus, brevis. They are done with histology, anatomy, upper limb, lower limb. Now coming to head and neck. Yeah. So over the last year, they've asked this. Nerve emerged at the market point, okay? Yeah, you can, I try to identify the nerves here. This is the region of the midbrain. This is pons, and this is your medulla, right? So what are the cranial nerves related to the midbrain that you see here? Yes, this is your third nerve. Fourth nerve. What is special about the fourth nerve? The trochlear nerve is the only cranial nerve that comes from the dorsal aspect of the brainstem. Pinnadi irundhu munnadi varum. Okay, fourth cranial nerve, trochlear nerve. Over the pons, what do you get to see? This is the fifth nerve. Pontomedullary junction from medial to lateral. This will be sixth. This will be seventh. And this will be eighth. Okay, 6, 7, 8. Okay, now coming to medulla. Medulla, this is the pyramid. This is olive. Okay, and you see a sulcus running between the pyramid and olive, and behind the olive. Okay, so these nerves that you see here behind the olive, this will be 9, 10, and 11th. This is the spinal accessory which is coming from below. Okay, and if you see any nerve emerging between the pyramid and the olive at this area, that will be the 12th nerve. Now, what is the question asked? What is the nerve emerging at the point? 6th nerve. Okay, yeah. Going on to the next question. All the marked nerves in the given image cause movement of eyeball except, okay, I'll just mark it now, guys. Yes, this was also yeah, A, B, C, and D. Yes, what is A? A is Yeah, A is the optic nerve. Okay, optic nerve is not going to cause any movement of the eyeball. What is B? B is the third oculomotor nerve. C is the fourth nerve, trochlear nerve. Yes, and D here is the sixth nerve. Okay, can we try identifying the other nerves also here? What is this thick nerve that you see here? This is the fifth nerve. Okay, the fifth nerve. This is the internal acoustic meatus, where you get to see the seventh and the eighth nerve. This one here already shown in red color, that's the jugular foramen, the 9, 10, and 11th cranial nerve. This one lower down here, yes, that will be the 12th nerve. Okay, so this is a very, as I told you, topics are important. Adhe madri, certain images are very important. So this image with the base of, the cranial fossa showing the nerves emerging. Yeah, it's a very important image, okay? Again, what is the nerve supply to the marked structure in the given specimen? So that is the orbit. Orbit, you know, it will have a roof, floor, medial wall, and lateral wall. Roof, floor, medial wall, and lateral wall. Of the four walls, lateral wall mattumna ore muscle irukkum. Okay, all the other walls you'll have two muscles. Yeah, so these muscles which are closer to the eye, they are the recti muscles. What are they? Superior rectus, inferior rectus, lateral rectus, and medial rectus. Okay, in addition, over the roof you get to see the one muscle above the superior rectus. What is that? Levator palpebrae superioris. Adhe madri, medial rectus ku mala another muscle you'll get to see. That's the superior oblique. And one muscle here in the floor in addition, that will be the inferior oblique. Yes, now we'll identify here. Yeah, so you're going to tell me now. This is the lateral rectus. This is inferior rectus, medial rectus, superior rectus, isn't it? What is this one? Above the superior rectus, levator palpebrae superioris. This one, superior oblique. This is inferior oblique, right? So the marked structure is superior oblique and the nerve is trochlear nerve. Okay? Yeah. This is easy. Paradoxical breathing in patient is due to involvement of which nerve mark? Yes. So paradoxical breathing, the patient having difficulty in breathing because of the diaphragm, right? No, Shivam, please take you another chance. Yes, is due to diaphragm. What is the nerve supply to the diaphragm? Phrenic nerve. Okay. So now your job here is to identify the phrenic nerve. Can you identify this muscle here? This is scalenus anterior. So the nerve which is going to run on the anterior surface of the scalenus anterior is phrenic nerve. What is B? This is your subclavian artery, right? Winding around the subclavian, I mean, you can see that our nerve crossing the subclavian artery here. This is the vagus nerve, okay? And you see the trachea here, this should be the esophagus. Going in the tracheo-esophageal groove, the one marked D. Yes, that will be the recurrent laryngeal nerve, the right recurrent laryngeal nerve. What is one more C here? That's the sympathetic trunk, the cervical part of the sympathetic trunk. Okay. Yeah. So the same nerves, I'm going to show you another image here. Now you can see the scalenus anterior here. You can tell me what nerve is this? This is the phrenic nerve, right? And you see the subclavian artery. Yes. What nerve will this be? Vagus nerve. Right? And then you see the trachea, the esophagus behind. This will be the recurrent laryngeal nerve. Okay, now you see the cervical part of the sympathetic trunk. The same thing, we saw the cadaveric image. Now something more similar, but a cross-sectional diagram. Yes, you're going to tell me now. What is A? This is your trachea, right? This is esophagus. So what will A be? A is going to be recurrent laryngeal nerve. Very good, Shivam. What is B? That's the carotid sheath, yeah, with the common carotid IJV. So that's going to be definitely the 10th nerve, vagus nerve. What is C? Behind the carotid sheath. What is the posterior relation of the carotid sheath? The cervical part of the sympathetic trunk. Okay. Now what is D? So this is again a scalenus anterior. This is scalenus medius. So D will be, yes, phrenic nerve. And you see something here, right, between scalenus anterior and medius. This will be part of your brachial plexus. So these nerves are very important, and these images are also very important. The same nerves you're able to identify in all the three images because you have understood the concept. Okay, so if you understand the concept, you can get it done easily. Yes, there's another starry question. They keep asking in different format. Okay, pterion, pterion, pterion. So what is a market thing? That's the pterion, right? Now who's going to answer this? The vessel that underlies the market point in the image given enter the cranial cavity through which foramen? Yes, Shivam. Yes, foramen spinosum. So what are the bones contributing to the pterion? This will be the frontal, parietal, the greater wing of the sphenoid and the temporal bone. Right? It is the meeting point of the four bones that we saw, right? Okay, I've just put the questions. What is the artery that lies beneath it was one question 1 year. The anterior division of the middle meningeal artery. What fontanelle does it correspond to? The anterolateral fontanelle or the sphenoidal fontanelle that closes around 3 months after birth. Okay, fracture of the pterion, what type of hemorrhage you get? The extradural hemorrhage, which presents with a biconvex lens-shaped hematoma, right? And once they have asked which part of the sphenoid is present deep to the pterion, lot of options were given. The one that was best you can choose is, yeah, this one here. Can you see this one? The lesser wing of sphenoid, okay? The lesser wing of sphenoid. Of the options given, this was the best one to choose from. Yeah, the lesser wing of, these are the markings of the middle meningeal vessels. The impression that you see here over the bone, that the marking of the middle meningeal vessel. So the lesser wing of the sphenoid, it lies corresponding to the pterion. Yeah, this one will do. Fracture of jugular foramen presents as. So what are the structures passing through jugular foramen? Can you tell me? Which cranial nerve? 9, 10, and 11. And from the options given, you should know the innervation of the tongue. So this is the tongue. You have the sulcus terminalis. In front of the sulcus terminalis, what papilla do you get to see? The circumvallate papilla, right? So, yeah, the tongue, you can divide it into what part? Posterior most part, right? And then this is called the posterior 1/3, and then the anterior 2/3. And you have two sensations, right? What is that? General sensation, taste sensation. What do you mean by general sensation? Pain, touch, temperature, all that. Taste sensation, about whether sweet, sour, all that. Okay. So posterior most and posterior 1/3, not much problem. The taste sensation and the general sensation from the posterior most part of the tongue is carried by vagus, vagus, vagus. Yes, Gober. Yeah. And coming to the next one, posterior 1/3 of the tongue behind the sulcus terminalis, along with the circumvallate papillae, is by 9th nerve. Yeah. And the anterior 2/3 of the tongue, general sensation is by lingual nerve. Okay. Lingual nerve. Facial nerve has no role over the tongue. And special sensation, the taste sensation from the anterior 2/3 of the tongue is by, yeah, very good. The 7th nerve, chorda tympani branch. Okay, I thought you're talking about something else. Yeah, facial nerve, chorda tympani branch carries taste from the anterior 2/3. So what is the answer for this question? Loss of taste sensation in the, yes, this will be the right answer. Posterior 1/3 of the tongue. Okay. That is the jugular foramen which is pointed out. Okay, 9, 10, 11 cranial nerve. The syndrome related to it is the Wernicke syndrome, involving all the cranial nerves, 9, 10, 11. 1 year they have pointed out this. What is this foramen? Who's going to identify? Identify the probe foramen. You can identify the bone, right? It's the sphenoid bone. Yeah? Yes, Shivam, very good. That's the foramen rotundum. What is the structure passing through it? The maxillary nerve. From the middle cranial fossa, it enters the pterygopalatine fossa. These are the pterygoid plates. Okay, so the maxillary nerve, middle cranial fossa via foramen rotundum mulama, it reaches the pterygopalatine fossa. Now, who's going to tell this? What is this foramen? That is also there. Very good, Shivam. Yeah, that's the pterygoid canal. Okay, pterygoid canal, Vidian's canal. Yeah, very good. Yeah, once they have asked, they've given like name the foramina which is situated between these three bones: sphenoid, temporal, and occipital bone. Yes, so this is that part, the foramen lucidum. The yellow that you see here is the greater wing of the sphenoid. The pink is temporal, and the purple that you see here is the occiput. 1 year in your exams, this was a question. Name the foramen which is situated between these three bony landmarks. Okay. I'm sorry, the image got inverted, but what is pointed out is the sphenoid sinus. Yes, where does the sphenoid sinus open into? The sphenoid sinus opens into the sphenoethmoidal recess. Okay. Yeah. So, you know, there are three meatus. These are the concha, the space below the concha, you have the three meatus. This is the inferior meatus, middle concha, middle meatus, superior meatus. The space above the superior concha is the sphenoethmoidal recess. What opens into the inferior meatus? It receives the nasolacrimal duct. What opens into the middle meatus? The middle meatus is very important. You see a bulge there in the middle meatus. This is called the bulla ethmoidalis. What is the bulge due to? The bulge is due to the, that was asked once, it's due to the presence of the middle ethmoidal. Okay, middle ethmoidal irukradnala da and the bulge irukkudu, bulla ethmoidalis. Okay, so the surface receives the opening of the middle ethmoidal sinus, and you can see a small, this is the hiatus semilunaris. The floor of hiatus receives the maxillary sinus. The hiatus la mela pora pathukku peru ethmoidal infundibulum. The wall of the ethmoidal infundibulum will receive the anterior ethmoidal, and top will receive the frontal sinus. So easy ஞாபகம் வச்சுக்கணும் அப்படினா middle meatus, remember AMFM. Okay, anterior ethmoidal, middle ethmoidal, okay, and then frontal and maxillary sinus. Easy? Yeah. Superior meatus will receive the opening of posterior ethmoidal, and sphenoid sinus will open into sphenoethmoidal recess. Yeah, this was asked once. Which muscle helps in opening of the jaw? Of the 4 muscles of mastication, that one which opens and helps in opening is lateral pterygoid. Now you have to identify the lateral pterygoid here, right? Which one? You can make out the ramus, the mandible here. So which muscle is sitting on the outer surface of the ramus of the mandible? A. A is masseter. Okay. B is coming from upright and inserting into the coronoid process of mandible. That's the temporalis. Okay. I'll show the next picture here. Here. Yeah. So this is your mandible, right? You see, C, this is medial pterygoid. And this one coming towards the capsule of the temporomandibular joint, this will be lateral pterygoid. Okay. Yeah. So you should be able to identify in a coronal section image also. So this is your temporalis. This is your masseter. You can identify the medial pterygoid. This is the lateral pterygoid. Which one helps in opening of the jaw? Lateral pterygoid. Okay. Yeah. Which of the following is not a branch of facial artery? Yes. Easy question, right? Yeah. So the facial artery over the neck, what are the branches given? It gives the ascending palatine artery, Yes. Glandular branches to the submandibular gland, submental branch, and one more, the tonsillar, inferior tonsillar artery. Over the face, what are the branches given by the facial artery? Yes, inferior labial, superior labial, lateral nasal. So the mental is not a branch of the facial artery. And they've also asked over the years about inferior thyroid artery. They've asked about maxillary artery branches, external carotid artery branches. All these are high yield topic, right? This one, which of the marked structure doesn't contribute to the laryngeal skeleton? Yes. So what is A? A is hyoid bone. B another thyroid. What is C? C is epiglottis. Right? D one the again cricoid. So which of these doesn't contribute to the laryngeal skeleton? Hyoid. Okay, hyoid is a bone. The laryngeal skeleton is contributed by the cartilages. Yes, we are moving on to abdomen. This one they keep asking again and again. Rupture of the bulbar urethra does not cause extravasation of blood into which of the following spaces? Yes, that was a bit of a controversy topic, right? Yeah, so normally, as you see here, the abdomen or the fascia scarpa. Okay, so this is the penis, this is scrotum, and this is perineum. The lower part of the abdomen, the fascia becomes continuous with the, yes, the deep fascia of the penis, the dartos muscle of the scrotum, and the Colles fascia of the perineum. Okay, so this is important. This is the superficial perineal pouch, and idhukku mele irukkiradhu will be the deep perineal pouch. Coming to this, yeah. So this is the prostate gland. You can see the prostatic urethra. This is your membranous urethra. Here will be the bulbar urethra. Yeah. So this is the deep perineal pouch. This is superficial perineal pouch. Injury to the bulbar urethra. Yes, the urine can accumulate over the superficial perineal pouch, around the scrotum, around the penis. It can also go to the lower part of the anterior abdominal wall. Normally, it will not travel to the deep perineal pouch, okay? Because the Colles fascia is attached to the posterior part of the urogenital diaphragm, okay? But these are the bulbourethral glands, which you see in the deep perineal pouch. The duct will open into the superficial perineal pouch. So at times, here, rupture of this can, the urine or the blood can extravasate. So for a better option wise, if you see, it cannot reach the ischiorectal fossa at all, whereas it can reach the superficial perineal pouch, walls of scrotum, and the deep perineal pouch. Okay. And this one, which of the following is not from the posterior division of internal iliac artery? Yes. So you know the abdominal aorta at L4 is going to divide into common iliac. The common iliac is going to divide into, yes, in external and internal iliac, right? Internal iliac is going to divide into posterior division and anterior division. From the posterior division, we have three branches, SIL. What is it? Superior gluteal, iliolumbar, lateral sacral. Remember here, the superior gluteal is the largest of all the branches of internal iliac. Okay. And what are the branches coming from anterior division? Yes, it will be superior vesical artery, obturator artery, to the bladder. Again, middle vesical, to the rectum, middle rectal artery, inferior vesical artery, inferior gluteal, internal pudendal. If it is female, what will happen? In female, you have, additionally you'll get the vaginal artery. Inferior vesicle will be replaced by vaginal artery, and one more, uterine artery. Okay. Internal iliac, posterior division, SIL. Okay. Anterior division alone, you have to remember SOMI. Superior vesicle, obturator artery, middle rectal. Okay, this is middle rectal artery. Inferior vesical artery. Inferior vesicle, what did I tell? In the female, inferior vesicle will be replaced by vaginal artery. And then you have the inferior gluteal, internal pudendal. These are the terminal branches of the internal iliac. Uterine artery is coming from the anterior division of internal iliac artery. Okay. Which nerve is blocked when local anesthesia is given below the inguinal ligament during femoral vein catheterization? Yes. So when you're going to do some procedure for the entire lower limb, you want the entire lower limb to be painless, you can do femoral nerve, right? Okay, or sciatic nerve. But here it's over it's just for femoral vein catheterization and local anesthesia. So the skin over the front of the thigh is by, femoral branch of genitofemoral nerve. Got it. These nerves are very, very, very important in some form or the other. They keep asking it. Okay. So I've just put a picture here. Yeah. So this one that you see here below the rib, that's the subcostal nerve. We are not worried about it. The next one here that you see here from the lumbar plexus is the iliohypogastric nerve. Ida patti enna question ketirukanga appadina, this supplies the skin over the inguinal region. So they can shade the dermatome over here, this region, skin, and they can ask you, okay, so this part of the skin over the inguinal region is innervated by the, not actually done, okay, but yeah, they're not asked root values frequently. That's the iliohypogastric nerve. And the next one, very important that you see here, is the ilioinguinal nerve. What is this ilioinguinal nerve? What are the important things you should know related to it? In the ilioinguinal nerve, it will pierce, it will enter the inguinal canal by piercing the roof of the inguinal canal. Okay, it will not enter through the deep inguinal ring. Roof pierce panite, it will be a partial content of the inguinal canal, and then it will exit through the superficial inguinal ring. It goes to supply the skin over the medial side of the thigh. Okay, and then this is the genitofemoral nerve, you see piercing it, which will divide into a genital branch and femoral branch. And yeah, so the thing that you should know about the ilioinguinal nerve, this is the one, yes, and the genitofemoral nerve, these are most commonly involved in the, yes, in open hernia repair. Okay, these nerves are injured more commonly in the open hernia repair. The laparoscopic hernia repair most commonly involves the lateral cutaneous nerve of thigh. Okay, this is the one, the lateral cutaneous nerve of thigh is most commonly involved in laparoscopic hernia repair. This was asked in 2021. Which of the following acts as the pelvic diaphragm? I'll put A, B, C, D. A, B, C, and D. What is A? A is on the lateral pelvic wall, obturator internus muscle. B is the levator ani. C is the external anal sphincter. D is the internal anal sphincter. So the pelvic diaphragm is contributed by, very good, Dr. Jain. Yes, B. That was also asked, marked areas related to which of the following. So what is this organ here? That's your kidney, the left kidney, anterior relation, okay? So here you should remember, this will be the left suprarenal gland here. This will be the spleen. This scary area will be the region of the stomach and coming in contact with the left kidney. And here you'll have the tail of the pancreas. Here will be the coils of jejunum. And here you'll have the transverse colon is going to continue as the descending colon. That will be the splenic flexure of the colon. Okay, that area. So the right answer will be the gastric impression on the anterior surface of left kidney. Thorax, yes, we'll go to thorax. Few important questions in thorax. Arrangement of structures in the hilum of the given lung. So this is again the right lung, isn't it? Right lung. Yeah. So what is the arrangement of structures in the hilum of the right lung? Whether right lung or left lung, it will be like artery, bronchus, and vein. Right lung enna difference appadina, in the bronchus will divide into two. One goes above the artery, one goes below the artery. eparterial. The one which goes above the artery, we call it as eparterial bronchus. The one which goes below the artery, we call it as hyparterial bronchus. So the arrangement of structures from above below the right lung will be eparterial bronchus, pulmonary artery, hyparterial bronchus, and the inferior pulmonary vein. Yeah, they've asked it recently. This one, which of the following artery is not supplying the marked region of the given heart specimen? Okay, yeah. So yeah, we are just closing another 15 minutes, so I may not be able to give much explanation in this session. Yes, so the arrows pointing at the right ventricle, isn't it? The right ventricle definitely is going to be supplied by right coronary artery. So this is the right coronary artery. You can see the right coronary artery here. This is the left coronary artery. What is happening to the left coronary artery? It is going to divide into left anterior descending and left circumflex artery. The left anterior descending artery, of course, will give branches to supply the right ventricle. Okay. Then what is this marginal artery? Marginal artery is a branch coming from the right coronary which runs along the inferior border. That also supplies the right ventricle. Diagonal artery na enadhu? Left anterior descending nu sonna illaya. Idilirundu vara branches to supply the left ventricle. So diagonal artery will supply the left ventricle and not the right ventricle. Okay, so please remember that. This one, at what level is the cross section taken from? Okay, so yes, so any cross section CT you see from the foot end. So either right tarkum, either left tarkum. I'll just give one clue. Yes, Shivam, you're right. Okay, so here just one point to see here. You should remember T4, you see the arch of aorta, right? So this is the arch of aorta and you see 3 vessels coming from that. Okay, so if you see the arch, that will be T4. If you see ascending aorta and the descending aorta, that will be below T4, right? If you get to see the great vessels, then that is going to be T3. Now, what do you see here? You get to see the arch of the aorta and the opening of the vessels, just the opening. So this is going to be T3, T4. Okay, I won't take much time, but I'll just explain here. Inge enna paakringa, you see 3 independent vessels, right? So this we can go with T3. Here, as I told you, arch with the opening of the 3 vessels, T4. Here, this is the ascending aorta, this is descending aorta, and the pulmonary bifurcation you get to see here. This will be T5. Idhila, you get to see the chambers of the heart itself, the right atrium, the right ventricle. So that will be a bit below. Okay. So once they've asked this cadaveric, like the cross section, okay, in thorax. Coming to neuroanatomy. Yes, easy question. Correct statements about the internal capsule. Okay, so if you have done with neuroanatomy, you must be knowing this is the region of the internal capsule. It will have anterior limb, a genu, posterior limb, sublentiform, retrolentiform part. Right? The genu, which part of the body is represented here? The corticonuclear fibers, which are going to supply the head and the neck. Okay, that part is represented in the genu. Posterior limb, which part is represented? The corticospinal fibers for the upper limb, lower limb, the trunk. Okay, is represented in the posterior limb. So this point, internal capsule is projection fibers. Okay, so here the fibers for the upper limb and the face is represented in the genu, not in the anterior limb. Retrolenticular part as optic radiation, sublentiform part as the auditory radiation. Okay, Charcot's artery. What is Charcot's artery? The middle cerebral artery, okay, the branches of which it's called the artery of cerebral hemorrhage because they are very thin walled and they can rupture whenever the pressure increases. Okay, they are called the arteries of cerebral hemorrhage are the Charcot's artery. They supply actually anterior limb, genu and posterior limb. Okay, so Charcot's artery supplies posterior limb is also correct. The one which is wrong is this one. Okay, 1, 2 and 4 are correct. The following structure projects into which thalamic nuclei? So what is pointed out here? You see the region of hypothalamus. Which structure is pointed out here? The mammillary body. The mammillary body, you must be learning in physiology, right? Papillary circuit. So where does the mammillary body project into? Into the anterior nucleus of the thalamus, okay? So I'm not going into the details. Every nuclei you must be thorough. This is another region of the interpeduncular fossa. Here, can you identify the mammillary body? These rounded structure. So next time they can put a similar image, right? Asking the same question with a different image. You should be able to identify the mammillary body in this image also. It projects to the anterior nucleus of the thalamus. Okay. Damage to the marked structure results in paralysis of which of the following muscles? So what is this you're getting to see here? That's the posterior surface of the brainstem, right? The fourth ventricle, and the bulge that you see here is called the facial colliculus. Why is that bulge there? You get to see the sixth nerve nucleus. Okay, and the sixth nerve nucleus is going to be wound around by the fibers of seventh nerve. Okay, so when there's an injury to this structure, the one which is on the periphery, the seventh nerve will be involved. So if the seventh nerve is involved, which is going to be getting paralyzed? Lateral rectus nerve supply, another sixth nerve. Superior oblique, fourth nerve. Levator palpebrae superior is third nerve. Risorius muscle of the face is innervated by seventh nerve. So the correct option will be risorius. Okay. Lesion to the marked structure that was asked in 2019 would present with which of the following? So that's again the medulla. The one pointed is the pyramid. What underlies the pyramid is the corticospinal fibers. So lesion of the corticospinal fibers, yes, very good, very good. Contralateral hemiplegia, right? Embryology, yes, and we are finding out with this. What is incorrect match about the pharyngeal artery derivative? So, you know, there are 6 arches, right? Yeah. And the fifth one completely disappears. The first arch remnants will form the maxillary artery. Second arch remnants will form the hyoid and stapedial artery. Third arch is going to give rise to common carotid, external carotid, internal carotid artery. Fourth arch is very important. In a right side and left side, it is going to differ. What is happening on the right side? It is the fourth arch, right? On the right, this is joined by the seventh cervical intersegmental artery, and together they form the right subclavian artery. Okay, but what happens on the left? The ventral part of the aortic sac, the left horn of the aortic sac, the left fourth arch artery, and part of the dorsal aorta, all these 4 together, they form the arch of aorta. Upper left subclavian engirandu varapodhu. The left 7th cervical intersegmental artery separately will give rise to the left subclavian artery. Adhe madri, 6th arch also, both on the right and the left, it's going to give rise to pulmonary artery. Plus, on the left, in addition, what is this structure? Which is patent, the ductus arteriosus. Okay, it is present only on the left. Adhoda remnants enna form pannum ligamentum arteriosum. So this pharyngeal arch arteries, they keep asking repeatedly. So what is the answer here? First arch is maxillary, second, third is also right? Fourth one, fourth arch, yeah, 6th arch. Okay, so option A. And the last question for today's session, yes, which of the following are derived from the marked structure? So what is marked here? Yes, can you tell me? This is your surface ectoderm, right? This will be the, yes, this is the neural tube. What do you see below the neural tube? This is the notochord. Okay, and you can see the mesoderm here. This will be the paraxial mesoderm, which is going to form the somites. Yes, Krishnan. This is the intermediate mesoderm. This is the cavity that you see here, right? Lateral plate mesoderm. So this outer part of it will be the somatopleuric and the inner part is going to be splanchnopluric. Okay. Now this yellow arrow is indicating the neural crest cells, which are going to migrate into the developing mesoderm. And what are the structures it's going to give rise to? Remember HCG and poems, right? Yeah. So in the heart, H stands for heart. In the heart, what are the derivatives of the neural crest cells? It gives rise to the phonotruncal septum, which separates the aorta and the pulmonary trunk. And the endocardial cushions, which are going to give rise to the valves that separate the atrium and the ventricum, atrioventricular valves, and then the semilunar valves in the aorta and pulmonary trunk. C. What does C stand for? The cells that are going to arise from the neural crest, and that is the mnemonic is poems. Okay, the parafollicular cells of the thyroid gland. Okay, odontoblast, enterochromaffin cells. M stands for three things: melanoblast, the adrenal medulla, the cells of the adrenal medulla, the leptomeninges. What are they? The arachnoid and pia, right? And S stands for Schwann cells and the satellite cells. Okay, yeah. And what about G? G stands for the ganglia. All the ganglia that you know. What are the ganglia? The cranial nerve ganglia, the spinal ganglia, the sympathetic and parasympathetic ganglia. All the ganglia are going to arise from neural crest cells. Okay. So what will be the answer here? Yes. So phonotruncal septum, melanocytes, parasympathetic ganglia, and this. Okay. So 1, 3, 4, and 5. Okay, guys. So I hope, in 1.5 hours, we have been trying to cover whatever important that has been asked over the previous years, and the high yield topics, make sure you cover before the exam. Okay. Hope the session was useful. Do reach us with your feedback. Thank you, Medusane. Thank you, IMA. Yes. Thanks all.
Thank you, ma'am. Thank you so much. It was, as usual, a wonderful session. So from the starting, I am like, I was actually listening to personally for preparing my exam, and it was very useful. Thank you so much, ma'am. And now I'd like to call upon Dr. Jamuna, ma'am, if she is present to...
Yes, Raghu.
Yes, ma'am.
So good evening, one and all. It was such an amazing session by Dr. Raj Kohila. Really hearty congratulations, Dr. Raj Kohila.
Thank you, ma'am.
The way you have planned, the way you have delivered the content. Sometimes, like as medical teachers, always this question comes to us. Is teaching is definitely an art. So whether it is inherited or is it acquired? So I feel like generally, as an answer, we would say like with hard work, definitely we can acquire that skill. I feel you have really inherited that skill. You're a born teacher, a natural orator. So it was really, really amazing. And especially the histology part, like because being a pathologist, I could relate so much to it. So I was really wondering, I had a lot of take home messages from your session. So I felt, so this is the way I have to be teaching histopathology to my students as well. So it was really, really amazing. And the effort which you have put in, really, definitely, I know you will make a great mark in anatomy across the country.
Thank
really,
you,
God bless you and hearty congratulations, dear. I personally enjoyed the session. Thank you so much. Thank you.
Thank you, ma'am. Thank you, ma'am. Thanks all. Thank you, students.
Thank you, ma'am. Thank you. And as ma'am told, it was really wonderful session. And actually, she has taken a lot of sessions. If you see, all the 6 regions are being covered separately as a 45 minutes lecture, covering all the MCQs in that. I will share the link also after the session so that you can just watch that too. Thank you, ma'am.